Hello, and welcome to a Health Podyssey. I'm your host, Rob Lott. For each beneficiary under the Medicare Advantage program, the federal government makes a fixed payment to private insurance plans, which then assume financial responsibility for the enrollee's covered medical expenses. On one hand, this model in theory creates space for different plans to pursue innovative approaches to coverage in search of savings. On the other hand, it could also incentivize plans to avoid potentially high-need, high-cost patients while pursuing low-cost enrollees. And so, to temper these incentives, CMS applies a form of risk adjustment. Those fixed payments from CMS to managed care plans, they're higher for enrollees whose characteristics predict that they might be more expensive to cover. But now, echoing a lesson that I learned with particular poignancy after becoming a parent, we know that the most brilliant solution to one problem often provides the seed for an altogether new and just as frustrating problem down the road. This, of course, necessitates yet another brilliant solution. And so it goes. Well, as it turns out, that lesson applies here. The current approach to risk adjustment seems to have its own flaws, a fact which has led many policymakers to raise the alarm, and it has led researchers to explore how those flaws might be fixed. That's the subject of today's Health Podyssey. I'm here with Dr. J. Michael McWilliams, a professor of healthcare policy at Harvard Medical School and a practicing general internist with Brigham and Women's Hospital. Together with his co-authors, Dr. McWilliams published an article in the January 2025 issue of Health Affairs examining the use of patient health survey data for risk adjustment with the aim of limiting distortionary coding incentives. Their paper is one of 3 research papers in the issue, all of which simulate the effects of modifying risk scores in different ways. So let's get into it. J. Michael McWilliams, thank you for being here.
Absolutely. Thanks for having me, Rob.
Of course. So part of what makes this issue so fascinating to me is that there isn't really just one challenge or problem. It's sort of a bunch of different problematic incentives all sort of stacked on top of each other. So maybe we should start at the bottom of the stack. Currently, Medicare uses a risk adjustment model called HCC, hierarchical condition categories. Tell us a little bit about that. What exactly is it and how does it work?
Sure. Well, I think you did a great job of just covering some of the basics, Robin. The one thing I might emphasize there is that, one of the big motivations for risk adjustment in Medicare Advantage is that it's an individual insurance market, right? So we don't worry about this as much in a group insurance market where an employer, for example, is buying a plan for its employees. There's risk pooling and there's few options and everyone sort of gets the same plan. But in an individual market where everyone sort of is shopping for themselves and they have lots of options, that's when we worry about insurers distorting what they offer to engage in the sort of selection strategies that you were describing. And the thing I want to emphasize there is that's not only bad for the people that the plan is trying to avoid, it's bad for everyone. And it's bad for everyone because often the plans will use tactics that are kind of crude, like restricting provider networks. And those sort of blunt strategies can diminish the value for lots of people. So this is sort of not just a problem for the folks that the plans are trying to avoid, but actually sort of for the entire market outcome, and just to sort of underscore the importance of risk adjustment here. So in the Medicare Advantage program, the bulk of the premium is paid by the government, right? And so what ends up getting risk adjusted is that payment, that capitation payment to the plan, and the HCC model or the hierarchical condition categories model is the thing that Medicare uses to do that. And it's been around for a while now, about 20 years. And so a little bit of what's going on under the hood. So basically what Medicare first does is it fits a model that predicts total medical spending in traditional Medicare at the beneficiary level as a function of the beneficiary's diagnoses that have been recorded in Medicare administrative claims data. And that produces a set of coefficients or payment weights that then can be applied to anyone else. So those then can be applied to someone in Medicare Advantage to calculate a risk score, and that risk score determines how much the plan gets paid for that enrollee. The more conditions, the more costly the conditions that the enrollee has, the higher the HCC score, the higher the plan, the payment to the plan. So that's basically how it works.
Great. So that's, correct me if I'm wrong, we've seen stories of sort of plans basically seeking out additional diagnoses for some of their enrollees in order to increase the risk adjustment. Is that a fair assessment? And am I sort of describing the potential, the problematic element of this approach to risk adjustment?
Yes, I think you hit the nail on the head. That is the main problem at this point, and it's very well known, very well described. The model basically rewards coding of more diagnoses, so those incentives are there. But the thing is that is coupled with an ability of plans to influence how many diagnoses are coded, so that the plans can influence the coding both directly. They can conduct chart reviews to add diagnoses. They can send a nurse to an enrollee's home to do a health risk assessment to collect more diagnoses. They can also influence it indirectly by incentivizing providers to add more diagnoses when they see patients and submit their claims. So basically, the main issue at this point is that the system is manipulable. Now, some of that coding activity is surely fraudulent. How much, it's unclear, but a lot of it, if not most of it, is probably just more complete or accurate or maybe aggressive coding where diagnoses are kind of squishy. And so if it is just sort of mostly more complete, that raises the question, like, is this really so bad? And the answer to that question is yes, it is. It's bad. It's actually really bad. And there are at least 3 reasons why. I think the first one gets the most attention, and that is that as Medicare Advantage plans code more intensively, their payments from Medicare are allowed to rise above what the law intends, which is basically some function of spending in traditional Medicare. So it poses a cost to the Medicare program, and this sort of subsidy for coding, based on most estimates, is basically the estimates peg it somewhere between big and huge. So this is a substantial subsidy going to the Medicare Advantage program. And then the other 2 reasons I think receive a little less attention. So second, even if we eliminated the program-wide subsidy or the average overpayment, there would still be the problem that plans vary a lot in how intensively they code. And so that distorts how resources are allocated, because a good chunk of payment is then going to plans not based on how much care their population needs, but just based on how well they code. And the consequences of that could actually get worse if we did something fiscally responsible and eliminated the average overpayment to MA to make it sort of a zero-sum game, because then you have this situation where money gets transferred from the worst coding plans to the best coding plans. Like the more one plan codes, they take more money away from their competitor. And so that could make the bad coding plans sort of go under and leave the market. So that's probably not desirable. And then the last reason is that the effort that plans exert to code more intensively consumes resources, scarce resources. And so even if we wanted to increase payments in MA above the levels of spending in traditional Medicare, which may be a reasonable thing to do if we want benefits to be more generous, for example, this is just an incredibly inefficient way to accomplish that goal. It would be far more efficient to just increase payments.
Mm. It seems like this could have been foreseen What obstacles have prevented us from tackling this before, or have we tried and failed?
One answer might be that risk adjustment is just hard, and it takes time to develop the technology to figure out how to do it well. I don't think, if that answer was the real answer at some point, I don't think it is anymore. I think we have a good handle on what to do now to move forward. Even setting aside the idea that we develop in our paper, there's plenty we can do. We can strip out the more manipulable elements from the HCC model, and we can use advanced predictive techniques like machine learning, other supportive tools like reinsurance to make the entire system sort of work better. And I won't get into any of that, but the point is that we have the technology. We can look to what other countries are doing. We can easily make progress here, at least from a technical perspective. So I think the real answer at this point is much more that fixing risk adjustment presents a really thorny policy dilemma because it means cutting benefits. And that's because the coding subsidies that we talked about have been a pretty major source of financing for the extra coverage that makes Medicare Advantage so popular. And popular for good reason, like that. Those extra benefits can be valuable because if you think about it, the basic benefit in traditional Medicare is not great. The insurance value of the basic benefit is actually pretty lousy because there's no out-of-pocket maximum and there's high cost sharing. Beneficiaries end up having to spend a lot of money on premiums in traditional Medicare just to get decent insurance coverage. And then they still face high out-of-pocket costs for dental, hearing, vision, long-term care, up to $2,000 for drugs. So it's very reasonable to want to improve coverage above what's in traditional Medicare, and subsidizing MA has been sort of our backdoor way of sort of accomplishing that. And so I think then what this means is that we are going to have to couple risk adjustment reform with some other way of financing better benefits in Medicare if we don't want enrollees to lose some probably valuable coverage. There would also be some political consequences, for cutting payments and having those benefit losses occur. But basically, because we can't fix risk adjustment in a vacuum, that's why it's hard to do.
Okay, so it's pretty clear there's a lot of room for improvement here, which brings us to your paper. Can you describe the theory behind it? What is the potential solution that you're evaluating?
Happy to do this. And so it may be worth just taking a little bit of a step back and thinking about what we're trying to do in risk adjustment, because the paper focuses a lot on the various trade-offs. You said at the outset that risk adjustment has to sort of accomplish a bunch of different things. Aaron Schwartz wrote a very nice accompanying piece in the issue along these lines. And so the thing I sort of wanted to emphasize, and maybe if there's one thing I hope listeners take away from this conversation, this would probably be it. And that is that there are these trade-offs, and the thing that often gets overemphasized, which is predictive accuracy or fit. And by that, I mean how well the predicted spending from the model lines up with the actual spending for a given enrollee. That improving that always comes at a cost, or usually comes at a cost. If we just add more stuff to a risk adjustment model, that's more stuff that can be gamed. Adding more stuff to the model can also weaken incentives for plans to make care efficient. For example, you could put a lot of markers of utilization in a risk adjustment model, but then you have a situation where payments go up as utilization goes up, and you're kind of defeating the purpose of contracting with plans, which is to control utilization. Same even goes for diagnoses in the HCC model, because they are indirect markers of utilization. So the more care use, the more claims, the more opportunities to capture those diagnoses. So the goal here is really more than fit. We shouldn't be describing the goal of risk adjustment as sort of a statistical goal of maximizing fit. We need to be thinking about it more in economic terms as getting the risk adjustment system to support the broader goals of the payment system and of the Medicare program. So the piece of this that we focus on in the paper is the properties of the inputs that go into the model. That's really the core problem that we're facing right now, is that we have these inputs in the model that are manipulable. And we pose the question, can we come up with a set of inputs that is not only less manipulable, but just as predictive, if not more so? Because it's very easy to take stuff out, but you run into this trade-off between mitigating coding incentives and mitigating selection incentives. And that's sort of what we're grappling with here. And that's basically because some inputs can be both manipulable and predictive. So here's the big idea that we explore. Imagine that instead of relying exclusively on diagnoses submitted by plans and providers, we set up a system for assessing the health status of a population in a more independent and standardized way. And so that would include, for example, survey efforts to collect data on a sample of each plan's population. That's the sort of vision that we explore. It's not a new idea. Many others have suggested drawing from survey data. What we did, I think, is a little bit unique in terms of considering those trade-offs and demonstrating that, yes, we can both scale back the HCC model to make it less manipulable, and then also draw from survey data to make it more predictively accurate and better align payment at a population level with markers of healthcare needs. So we can kind of move the system in the right direction along all these fronts by focusing on this core problem, which is the inputs.
Great description of the big idea. I'd love to hear more about how you evaluated that idea. We'll take a quick break and come back to that in just a second. And we're back. I'm here with Dr. J. Michael McWilliams. You just described sort of the big idea behind your paper. I'm curious how you went about evaluating it. And I know in particular you focused on a population of ACO beneficiaries. And I'm curious why you decided to focus there.
This is the reason why why researchers do a lot of what they do, which is that's where we had the data. So that's the main reason, is we had some nice survey data on patients in ACOs that we could connect to claims data, but this could be done for the MA population as well with the right data. And these issues around risk adjustment relate to both MA and ACO programs. But I think for the purpose of this conversation, we can think about sort of the implications really more for Medicare Advantage. So what we did is pretty straightforward. We start with the HCC score, and then we create two other scores by changing the input variables that are included in the risk adjustment model. So the first score that we create, we do so by removing 10 condition categories from the HCC model that Rick Kroenig and his team in one of the companion papers found explain. These are the ones that they found explained a large share of the difference in coding intensity between Medicare Advantage and traditional Medicare. So we can think of these conditions to be sort of among the most susceptible to coding practices. So we get them out of the model. And that's all we do in that first score. We call that the HCC subset score. And by design, that should be far less manipulable and limit coding incentives. But as we were just discussing, when we pull that information out of the model, the fit of the model suffers, so we worry about exacerbating risk selection incentives. So that motivates the other score that we created, which we did so by combining the HCCs from that subset score with a set of variables from a national survey on Medicare beneficiaries, focusing on the ACO population, as you said. This is from the Consumer Assessment of Healthcare Providers and Systems, or CAHPS. And so the variables included just a couple handfuls: self-reported general health, self-reported mental health, a set of questions on functional status, activities of daily living, and a few self-reported chronic conditions. And then basically, we do a bunch of analyses to understand the properties of this score, which we refer to as a hybrid score. And what we're trying to do is deduce whether it outperforms the HCC score, not just in fit, but in some of these other important ways.
And what did you find?
I may have already, spoiled the surprise. The findings are sort of encouraging. We do find that the hybrid score predicts spending at the beneficiary level more accurately than the HCC score. The improvement is not dramatic, but the key is that the addition of the survey inputs, which we believe to be less manipulable than the ones that we pulled out, more than make up for those HCCs that we removed in terms of fit. The second big finding is that at an organizational level, the hybrid score distributes payment in a way that is more in line with markers of population disease burden that should not be as influenced by coding practices or utilization patterns as an HCC score. So those markers that we looked at include mortality rates, hospitalization rates, use of prescription drugs. So the hybrid score distributed payment more towards the organizations that had higher levels of those indicators. And then interestingly, when we looked at an organization's use of more discretionary services, we found the opposite. The hybrid score actually distributes payment to a lesser degree according to those more discretionary services, which we interpret as a good thing. In other words, whereas overuse might lead to higher HCC scores because the more claims, the more utilization, the more diagnoses that go into the HCC score. That seems to be less of a concern with the hybrid score. So we wouldn't be rewarding sort of the more profligate organizations using this hybrid score. And then one of the other findings is that the hybrid score also distributed payment towards organizations that disproportionately serve certain underserved groups. So it seems to have some nice equity properties as well. And then we did a bunch of analyses to probe the challenges of using a score like this, that these challenges come up because you only have a score that draws from survey data for a sample of people, for the survey respondents. And so those issues are, mainly sampling error and non-response. And I won't get into everything we did there. But the bottom line is that we didn't find any evidence that those issues should be prohibitive. The challenges are real, but it seems like they can be dealt with. And I should say that all of this is proof of concept. We're not sort of putting this score forward as the thing that CMS and Medicare should use necessarily. Right. We're just saying this can be done, even with existing survey data, which could clearly be built upon and expanded, made better. But we can employ this strategy to make the system work better.
Great. So that makes sense. Proof of concept. How do we get from there to, CMS implementing a new approach? Obviously, more research is needed, but where do you think both researchers and policymakers need to go from here if we're looking at this paper as sort of a starting point?
Well, I do think that more data collection would be helpful. There is enough existing survey data to advance the research and the know-how, but the performance of the score will only get better if we collect more data and try to address things like low response rates. But again, those issues can be dealt with. It's just a matter of making the strategy work better. But I do see this more as a sort of, 4 or 5 years from now, after putting in some time to build the technical capacity, but then also think about the data collection that would be necessary. In the interim, and this is really not what our paper is about, but I do think that we can do things along the lines that Rick Ronick's paper suggested and couple them with other ways that improve fit. So whether that's machine learning or reinsurance, there's ways to take some existing off the shelf things and make the system work better. And then if we get to a point where we can collect some data in a more independent, standardized way, then things can only get better from there.
Okay, so also in the meantime, as it were, this is all happening at sort of a bit of a turning point or a crossroads for the Medicare writ large, which is that over the last few years, we've seen a rapid increase in the share of Medicare beneficiaries choosing Medicare Advantage over traditional Medicare. I may be overstating how rapidly it's happening, but at this point, I believe we're at more than half of beneficiaries choosing Medicare Advantage. And I'd love to hear your thoughts on sort of what's behind that change and how your exploration here intersects with those challenges.
I think your characterization is right. MA's been growing fast. And among eligible beneficiaries, those enrolled in both parts A and B, the share that's enrolled in MA is substantially higher than half now. It's probably close to 56, 57%. We'll see when the enrollment numbers come out for January, but it's getting high. I wish that I could say that the growth has been entirely due to sort of what MA was envisioned to do, which is sort of generate efficiencies and then convert those efficiencies into extra benefits for enrollees. That's going on to some extent. But clearly, these large payment subsidies from not just coding, but also favorable selection, quality bonuses, generous benchmarks, all of that is a big driver of the more generous coverage that MA offers. And that makes a lot of sense given those subsidies that MA is growing fast. I mean, if we're spending 15, 20% more on Medicare Advantage than traditional Medicare, we should certainly hope that MA is growing fast. If it weren't, that would be a huge red flag. And in terms of how this intersects with sort of risk adjustment solutions, as I noted before, fixing risk adjustment would, all else equal, reduce payments and lead to some benefit losses. And given that, I'm not sure if this is dodging your question, but I the first thing I'll say is I'd like to just see a more direct policy conversation about what to do about that. And I can lay out some options, but I think the conversation about fixing risk adjustment and MA payment policy has not been the most direct conversation. And so it's very clear what's going on. It's very clear what the options are, and we should be discussing them. So one option is just fix risk adjustment, do nothing, and then payments get cut and beneficiaries would lose benefits. And the question then is how valuable are the benefits that are lost? A no-brainer thing we can do that we should be doing anyway is to try to strengthen insurer competition in MA. So, for example, if we can help beneficiaries shop for the highest value plans, that should pressure insurers to pass along more of their profits to enrollees as extra coverage. And right now, they keep a lot of that surplus. And if we could do that, then payment reductions wouldn't have as big of an effect on benefits. But that's hard to do. Strengthening competition is not easy to accomplish. And so then policymakers might want to implement some compensatory payment increase to moderate the payment reduction and benefit losses from fixing some of these other problems in MA policy, particularly, what's happening with risk adjustment. And there are basically two ways to do that. One is just to increase payment only in MA, and that would perpetuate the favorable treatment of MA just to a lesser degree. The other would be to improve the basic coverage in traditional Medicare, maybe add an out-of-pocket max, some more reasonable cost sharing. That would increase spending in traditional Medicare, so we would save less money from fixing risk adjustment. And by increasing spending in traditional Medicare, that increases payment benchmarks in MA, so that would moderate the net payment cut. I tend to favor that latter strategy because I like the idea of a more even playing field between the two programs to sort of apply more competitive pressure on MA plans to generate more value.
Can you say a little more about sort of the practical benefits of improving risk adjustment? I know we've just spent the last half an hour talking about reasons why this is a worthwhile policy goal, but I'm curious to hear your thoughts about how this might be experienced by a random Medicare beneficiary who doesn't know about risk adjustment, let alone understand it. How are you going to see the changes as a 67-year-old enrollee who's just sort of trying to make decisions about which plan to choose for the next year? Are they going to notice it at all? I mean, you alluded to some of the potential changes in benefits, but how does that sort of trickle down for someone on the front line?
Well, if we think about one of the consequences being lower payments, and it's not exactly clear how much lower the payments would be. We think substantially lower if we really made the model, if we just eliminated the extent to which it could be sort of influenced for gain. We think that the payment reduction would be pretty substantial, maybe 10% or more. So the question then is, what might we expect from that? First of all, that beneficiary's plan might exit the market. The more generous the plans, the more that invites entry, and it's not the best way to encourage competition to just pay more, but that's sort of one of the effects, and so we might have fewer options. And then I alluded to sort of cuts in benefits, and I think then your question is sort of, well, what does that mean, right? What is that for the beneficiary? Generally, what plans have been able to pass through to enrollees, whether it's through the savings from more efficient care or from these payment subsidies, has been extra supplemental coverage, so lower cost sharing. That's sort of better than the basic TM benefit, and out-of-pocket max, more comprehensive drug coverage. And so they do this. They add coverage, and the premiums don't go up. So basically, what beneficiaries, when they're going to make a choice, see is very high premiums on the traditional Medicare side to get a bunch of supplemental insurance, much lower premiums in MA to get supplemental and drug coverage. And then the other main thing that plans pass along to enrollees are various types of supplemental benefits. The most popular are probably dental, hearing, and vision, but there are other things that plans have begun to make available, like transportation benefits, meal, even check cards for meals and produce and healthy food. So the benefits have gotten increasingly generous as the payments have gotten more generous. I wish I could tell you, dollar for dollar exactly what would be lost based on, however big the cut in payment is. That's an empirical question, and there's some good studies that try to approximate what the effect would be, but it's hard to know.
Fair enough. Well, before we wrap, I did want to just take a step back with you. You've been in this field more than 20 years, I think, and I'd love to hear what maybe the biggest change in healthcare you've seen since you've started your career.
Yes. That is, I'm still trying to get over, Rob, the 20 years that you're...
Sorry to put a fine point on it.
Yeah. I have mostly studied the Medicare program. My interests have been broad, and I've studied a lot of other topics, but that has generally been the focal point of my research and a lot of the engagement on the policy side. I do think that probably the biggest change has been this growth of Medicare Advantage and just the much different Medicare program that we have now. And so I end up, I guess, thinking these days a lot about how we should reform the Medicare program going forward. And there's a lot of debate on this, but not a whole lot of clear policy direction emanating from that debate. And I think it's become pretty polemical. There's a lot of ideological exchanges and a lot of painting of each program with a pretty broad brush. And so I don't know if that's answering your question, but that's sort of a big change that I've seen and continues to interest me, and where I think we ought to be having a clearer discussion. And I think that in the debate over Medicare, we would benefit from having a little bit more honesty on both sides. I think for the proponents of MA, I think the MA has a lot of promise, but clearly the game is rigged in MA's favor. The subsidies have gotten out of control. Competition is limited. Insurers are keeping too much of the money. But it also has clearly demonstrated an ability to be more efficient in terms of utilization management. And traditional Medicare has not fared well there and doesn't have much in the way of cost control measures, although I do think the ACO programs can be better designed to do that. So neither program is really where we want it. And I think what sort of frustrates me most about the debate now is that there's a lot of confusion between concept and execution. So when the concept of MA or ACOs is poorly executed because of design flaws, there's a tendency for some people to just sort of trash MA or trash ACOs. But in reality, we get out of the Medicare program exactly what we designed it to deliver, right? And so my general view is let's improve the design of the program. And that's sort of what I've been following, what I'd like to see more conversation about.
Great. Well, a good agenda for the conversation to continue. Thank you so much for taking the time to chat with us today. Really appreciate it.
Thank you, Rob. Really, really fun talking to you. Thanks.
And to our listeners, thanks for tuning in. If you enjoyed A Health Podyssey, please recommend it to a friend and tune in next week.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.